touch on basic oxygen therapy. This is a complete open discussion, so if you guys have questions at any time, feel free to just yell them out. That doesn't bother me at all. I know that some people are sort of like, save your questions till the end. I fear that you'll forget them or like we'll just get off track. So whatever you guys feel like. Cool. Some of it might seem basic, but I'm always surprised who I'm talking to when I'm like, but you understand, and that's the basic idea behind that, and then I realize that that's not the case, right? So whatever it is as basic as you think it is, if it is basic, I just hope that I have the right answer for you. Hopefully that is the case. So what we're going to talk about is the interfaces that you can use for oxygen therapy, and I'm talking like nasal cannulas, the different type of masks, things like that, right? And then the delivery method, meaning is it on a flow meter, what type of flow meter is it, and then we're going to touch on a little bit the RSV bronchiolitis protocol stuff, and we'll go over the high flow nasal cannula pull and what that means to you guys. Cool? All right, so as a respiratory therapist, right, on the floors, our jobs are, I wouldn't say relatively easy, we just have a very narrowed focus, and specifically with you guys, right? So it is one of those floors where we just have not been able to breach the subject of like RT-driven protocols up there, and that's been okay. I think that the PAS, the pediatric asthma pathway, which is soon to be a protocol, we're going to go in front of MedExec a little later, the 6th, is that tomorrow? I should probably prepare for that. Yes, and we're going to try to get it passed as an RT-driven protocol, and that will be the first thing that RTs will have, where I can walk up to your floor, score that patient out, and be like, you know what, now I'm going to change that score, and I don't need to go find anybody else. We'll still collaborate, that's the whole jam, right? So, but from there, hopefully we should be able to change orders. As it stands right now, there is nothing else, okay? The only thing that I really truly have freedom on is going up to your floor and just kind of running a nebulizer. I can't change frequencies. I can set people up on oxygen. We can titrate as you guys find necessary and all that fun stuff. So when it comes to oxygen, the things that we can use as far as interfaces go are usually something along the lines of a nasal cannula, some variety of face mask that we could have, a head box, which I'm not pointing at you, right over your shoulder, right over there, which is just simply an oxygen-rich environment. You guys probably see that pretty infrequently, and I'll talk a little bit about that a little more. Okay, so the first thing, we all think that these things are easy, right? Flow meters. There are so many different flow meters that are out there on the market, and I gotta pick through all of them and find out what is what and what is the best, and which calculation do we want? Is it a quarter of a liter? Is it 250 cc's? All that fun stuff, okay? So take these recommendations that I have up here with a grain of salt, like the 25 cc's and up to 1 liter for neonates and on and on and on, okay? What we truly have to think about is when you take one of these flow meters and screw it into the wall, what's coming out of that wall is 100% oxygen, straight up, and that's just, that is what it is, okay? So when you do that, with an adult, because of our tidal volumes and basically how big of a breath we're taking, I can entrain, or we all can entrain air around that nasal cannula, so we're pulling room air in at the exact same time. So that 100% that's coming down the tube is now being diluted, so in adults, we can guesstimate that at 1 liter, we're sort of getting 24%. At 2 liters, we're getting 28%. And for the rest of you math whiz people in the room, just keep adding 4 every time we add a liter to it, okay? So just to show you that, this would be just a basic nasal cannula that you guys are going to see up on your floor. It's a great idea to put the little bubble bottle on there. It's not going to harm much of anything, okay? The problem is, if we just hook somebody up to the wall and it's just running 100% out of the wall, depending on its flow rate, we might be drying their nose out, right? And I'm not saying it needs to be heated and humidified. We're about to get into some calculations here that'll explain that a little further. If that were the case, then we're going to something like this, which has a built-in heater on it, right? So, nasal cannula, coming through a little bubble bottle. Hopefully we don't dry out the nose. We don't want bloody noses, right? We don't want the patient to be uncomfortable. But what you have to be aware of, regardless of what size cannula or what patient, if you put this thing through or over 6 liters, eventually we're gonna have like a wet t-shirt contest because this bad boy is gonna explode all over everybody, okay? So nasal cannula to this, 6 liters, that's your max, don't go any higher. Sound good? Okay.
Going higher than that.
I know.
Say what?
I said, I hope we're not going higher than that on the floor.
Correct,
Yeah.
correct, and we're gonna get there. Although you say that, but I visited and been like, what are we doing? What are we doing here, right? Okay, do you guys know the difference, and don't point out this thing behind me, the difference between high flow oxygen and low flow oxygen? If you think you do, just spit it out. Or just totally remain silent, that's also fine. Okay, low flow oxygen is when you do not exceed the patient's inspiratory demand or their minute ventilation, right? And so what their minute ventilation is a calculation of their respiratory rate times their tidal volume. That tidal volume is how big of a breath are they taking in, okay? So if you exceed the combination of those two things, which I'll show you the calculation, you are now giving high flow oxygen to that patient. And that should never actually be our goal unless we're headed to this pole over here. There are high flow oxygen devices that do not provide heat and humidity, and that would be your venti mask, okay? So the venti mask can go from 50% all the way down to 24% FiO2, right? And so you're sort of like 24% FiO2, that's super low. Why would you consider that a high flow device? It's because I'm gonna take this, I'm gonna hook it to that flow meter, right? And now the amount of flow that's gonna come out of the flow meter, because it tells me right on the bottom of this how much flow to put through there, is enough that they're not gonna entrain anywhere. It's all gonna come through this mask and just go into their nose. There is a little entrainment device that's right here, can you guys see that? And that's attached to these little guys that allows so much air to come from just room air. And so now that is entraining in there. So we're giving a precise amount of flow or oxygen at a higher flow rate to get to your patient, okay? That's ensuring that if they have an oxygen requirement, then we want to sort of help them with that work of breathing, but we're aiming more towards SATs. We're not gonna allow them to try to entrain any more air. We're just gonna take it over and say, this is exactly what you're gonna get, right? So it's a little bit more control. The problem with the nasal cannula is we don't know exactly what your patient is getting for oxygen on this nasal cannula. If I just told you it's coming out of the wall at 100% oxygen, what does that mean to what size patient? I'm not really sure, and so it can go to a really simple calculation, and it's right there. Can you guys just memorize that down, right? So this calculation was set up for something that was called the stop-ROP chart, which is stopping retinopathy. It was initially so we could look at neonates and how much oxygen those guys are going to, okay? So you have two choices. Figure out this calculation, right, which I expect absolutely nobody to do, or we can go to our stop-ROP chart, which I'm hoping I have up, which is this guy, right? It's 2 pages of simplifying that calculation. Basically, what this is showing, let's just say I have this like 2.5 kilo kid right here, okay? And then their flow rate is 2. You guys following me? I'm gonna go over to that zone. This is giving me a factor of 67. And then I would go down to my next chart, and I would find that factor of 67 if it's there. There it is. And then I would go over to how much oxygen is actually coming out of the wall. That's going to be represented on this top line over here. So you would think, well, Ryan, you just told me 100% oxygen is coming out of the wall, but some places like NTS or the NICU or PICU, they have blenders, right? And that blender is this guy right here. And so the blender can be anywhere between 21% all the way up to 100%, right? So for you guys, in this case, it's coming straight out of the wall. That's 100% oxygen, right? You guys following me? Sort of, kind of?
Yeah.
So we would go to that factor of 67, and then we'd go all the way across, to where our 100% is, up there. Follow it down. So we could assume that that patient was actually getting about 74% FiO2. Pretty confusing, right? So option C, not confusing? Okay, good, we'll go with that. Option C is just assume they're getting a whole bunch of oxygen, straight up. Cool? Does that sound good? So it's not one of those things where you're like, oh, 2 liters, that's like 28% oxygen, who cares, we should be good. That might not actually be the case. So have you guys looked at the bottom of these little venti situations that we got going on here? So on one side of it, here, I'm gonna pass them down. I see you shaking your head, yes, but just in case. On the lower portion of this, it's gonna say what liter flow to set that on, and then how much FiO2 the patient should be getting.
So this is what the oxygen tube. That mask. We just hold up the mask.
Do what? Oh, yeah.
Please.
This
So
guy?
where that orange piece
Oh, do you want to
comes
see
on.
how it connects into it
Yeah.
as well?
And then the oxygen tubing goes in here, so that's the amount that the.
It's like a puzzle.
Like this.
And I get this call all the time where we're like, something's out, right? And I go out there and just one piece of the puzzle is out.
Oxygen, and that's what comes out.
The mask goes down into the corrugated tubing, right? The fastest way to do this is to get this little piece, which is the air entrainment piece, down into the plastic. And then that connects into your tubing. Oxygen tubing just goes to the wall. Look at the bottom of it, what liter flow do I want to do? Bam.
When you connect those two pieces, does it matter which direction the airflow piece is pointing, or you just pop it on and it's good to go?
Totally. Well, no. Which direction around here? No,
Okay.
that doesn't matter at all.
Okay.
The only thing I would recommend is try not to have it actually facing the patient where
Oh, like down.
it could just
instead.
occlude on their shirt, right?
Right on.
Yeah.
Okay.
So, no, it's a super good question. Feel good about it? Okay.